Hi, I am Dr. Vidushi from Suvi Eye Hospital, Kota, Rajasthan, and in this video we describe the technique of transpupillary removal of silicone oil with a phacoemulsification in eyes that have undergone pars plana vitrectomy with silicone oil injection for a complicated retinal detachment. Now in this particular case, this was a 45-year-old male who was operated for retinal detachment and had undergone a vitrectomy with silicone oil injection about 3 months ago in the right eye, and he then presented with grade 3 cataract. The posterior segment was stable, the retina was attached, and there was no problem in the retina. So he was scheduled to undergo a phacoemulsification along with the transpupillary removal of silicone oil through the posterior capsular axis and IOL insertion. Now this is the posterior subcapsular cataract in a silicone oil filled eye. As we all know, the posterior subcapsular cataract occurs in a large majority of eyes that have had silicone oil implantation, and even after the silicone oil removal, the cataract may present and progress rapidly. In these eyes, posterior capsular fibrosis occurs and may create problems. Now here we are doing the routine phacoemulsification with a side port incision. Viscoat has been injected into the anterior chamber to coat the corneal endothelium to avoid any corneal endothelial damage, especially during the silicone oil removal. An anterior capsular axis is then performed, followed by hydrodissection and hydrodelineation. We remove the cataract in a normal fashion, performing a horizontal chop and then aspirating the nucleus fragments. Once the cataract has been removed, as we can see here, there is fibrosis of the posterior capsule, which commonly occurs in cases that have had silicone oil. And here we can see the efflux of silicone oil through the zonules. So as we can see, because of the hemodynamic pressure, the silicone oil tries to come out into the anterior chamber, and once we make a posterior capsule opening, it will easily flow out and into the anterior chamber and out of the eye from there. So the posterior capsule is being punctured with a 20 small capsular axis. It is difficult to perform a posterior capsular axis in a thick fibrotic capsule. However, it can be done with experience, but we must be careful that this posterior capsular axis needs to be a small axis of about 4 mm size, so that the IOL that will be implanted into the capsular bag remains stable. As soon as the posterior capsule is opened, we can see the silicone oil coming out, and we then put an AC maintainer, and the silicone oil is removed by pressing the posterior corneal lip. So it just flows out due to the hemodynamic pressures from the posterior segment into the anterior chamber, and from there out of the eye as the posterior corneal lip is being depressed. So this is essentially a passive hemodynamic expression of silicone oil through the continuous posterior capsular axis. The AC maintainer helps to maintain the pressure and avoids any rapid hypotony, which may be a cause for a choroidal detachment. So with the AC maintainer in place, we continue to depress the posterior corneal lip till the silicone oil has been completely removed. The silicone oil that has been entrapped behind the posterior capsule can also be removed by similarly depressing in the area where the silicone oil is coming out. Here a 3-piece Sensar IOL from Abbott Medical Optics is being injected. This IOL is implanted in the capsular bag. A single piece IOL may be preferable for some surgeons. However, whatever IOL we use, it should be implanted in a slow, careful manner with slow and controlled unfolding. And of course, needless to say, silicone IOLs are completely avoided, and an acrylic IOL is preferable in these cases. The viscoelastic device is then removed from the anterior chamber and the capsular bag, and also some small bubbles of silicone oil can be removed by during this irrigation aspiration. The wound is then hydrated, an IOL that is well centered in the capsular bag, and the cornea looks clear at this stage. So to summarize, the advantage of hemodynamic expression of silicone oil through a planned posterior capsular axis is that it is quicker, it is a lesser invasive surgery, it obviates the use of creating pars plana infusion line and pars plana incisions, and it has been observed that the patients have a faster visual rehabilitation in the postoperative period. So in selected cases where the retina is attached and stable and there is no other retinal complication after previous vitreoretinal surgery, the silicone oil removal and cataract surgery can be performed in the same sitting by using this technique for transpupillary removal of silicone oil. Thank you.